let's talk about a couple other things. Get to radioligands in a second, but first, for the patients with BRCA2 or HR mutated patients, how are you guys looking at those patients? Obviously, we have the PROfound data from years ago using olaparib, then we have newer combination data. So how do you guys think about that? Are you using single agent at progression with castrate-resistant disease or a combination? It's a tough question.
Yeah, it is. It's a tough one.
Yeah, I mean, I think it all comes back to your molecular profiling and kind of making decisions in the castrate-resistant space depending on what you do or do not find. And when it comes to BRCA or other HRD mutations, certainly very exciting. And even considering PARPs in the castrate-sensitive space now with amplitude is also of consideration. So yeah, I think there is definitely, especially in the BRCA mutated population, improved efficacy with a doublet versus monotherapy. So depending on what they've had before, most of these patients are getting ADT plus an RP in the frontline setting. So you could, to some degree, question the utility of continuing an RP plus a PARP inhibitor in the castrate-resistant space, but a lot of times, well, I'll still consider doing so.
Yeah, I tend to go with single agent just because I don't know from an overall survival standpoint if I'm going to, benefit that patient. Side effect profile is a little bit better, but I don't think there's a right or wrong answer.
Generally speaking, patients come in differently and they'll say, I'm okay with taking a doublet, even if I understand that medication may not necessarily have as much of an effect as the single agent PARP, when you get to that space. A lot of my patients have been really, I'd rather just take a single agent and I'm a little bit medication fatigued once you get 1 or 2, 3 lines into medication, especially the oral agents. They have difficulty with counting it out and making sure that there's compliance with taking the medication. So I do agree with you that the single agent is the way that I usually go about doing that.
So how about radioligands? Obviously, we have lutetium, PSMA-617. There's the PEACE-3 data looking at enzalutamide with radium-223, kind of resurface this conversation. Are you guys, first of all, what do you think about the PEACE-3 trial and the results? Has that been incorporated in your practices or not yet, or maybe never?
It's tough because I like the data is really good with the survival benefit, and the problem that I see with this in incorporating is again sequencing on which drug sets. If once you use the enzalutamide plus the irradium, where does that leave your use for Pluvicto, and where does it give you an idea of like how do you do your doublet, what in the sequence, and how does that kind of affect that? I think this gives you another option for patients. It's certainly, for me, the struggle would be to try to incorporate where that would incorporate into the treatment modalities that I already have available, and then logistics of sending the patient to getting irradium.
Yeah, I mean, I think that study for me, a few of the problems would be most of those patients, so they're castrate-resistant, ADT alone. I think there were a few patients that got docetaxel, but a lot of them just ADT alone. So I don't know how to apply that now because, as we said, most patients are getting doublets or triplets in the castrate-sensitive setting. So yeah, we'll see. There will be more to come with that.
Yeah, I think at the very least, it gives you another option.
Yeah, there's activity, right?
Yeah.
So
outside of that, I'm just curious, where does radium fit into any of your practices? Is maybe the CRPC person, the symptomatic bone pain, bone predominant disease, do they need to also be PSMA not that avid? Is it, are you, how are you reaching for it? I think the one thing about, radium, most of our, radioligand therapy that's PSMA based is beta emitters, the radium's an alpha. There is a difference there. There's also a difference with understanding late toxicities, I think a little bit, not that everybody who's been on radium lived all that long, but we worry as we move PSMA up earlier for things like kidney toxicity, et cetera, over long periods of time. So where does radium fit into your three practices? Is it fit in at all? Can you remember last time you used it?
It's been a little bit since Pluvicto, so for me at least, you know, patients have kind of proceeded into a sequence where they receive the Pluvicto. I don't know for these gentlemen.
Yeah, I mean, I would say the same. I haven't used it. I'm encouraged by this data that there's an option, but I'm not using it early in the sequence. Lutetium is kind of, you know, preferred for our practice.
I agree. I mean, there's some data suggesting that a higher SUV on PSMA PET may respond better. So as you say, someone who may have a low PSMA, a low SUV on PSMA PET, maybe you're not as thrilled about Pluvicto in those patients, and it could be moving up the ranks a little bit more into the discussion. But just given how well Pluvicto has been tolerated and how and its efficacy certainly is something we're reaching for sooner and sooner. And even having data looking at it in the front line, I think with a presentation at ESMO coming up here will be pretty exciting to see.
Yeah, we're recording this before ESMO, but it's the press release is out, so it's exciting.
Oh, I was going to use a very old word, provenge, and just to bring that up as this conversation goes on in metastatic castrate-resistant space. Is anyone using this day and age, or are you?
I'm not using Provenge.
You're not using it?
Personally, no, but I know of some that are. Mm-hmm. And it's for those patients who maybe they're on ADT alone and there's very, very slow change in their PSA. There's, you know, they're slowly creeping up into that castrate-resistant space. That might give you a window to where you could still potentially explore the possibility of Provenge.
I mean, we're exploring some. We can talk about these studies later on. In immunotherapy space.
Don't have much use of Provenge at Northwestern. You know, as you mentioned, if there's any setting, it might be that. There was signal there again, but like it was hard to pin down the biomarkers and who would most respond. Maybe the black population. There was a lot of, you know, maybe the dendritic cell count, but a lot of that never bore out. And then other therapies came through that were more understandable, I think, and could deal with higher volume of disease. But I'm interested, maybe after this, we could talk about some of the studies that are emerging, because there is something to be said about the effect there. I wonder if I can go back and ask you all about, because we talked about PET PSMA imaging and radioligand therapy, and not to get into the nuts and bolts, for the people out there that are giving radioligand therapy, can you do a brief summary of like how you do it? Are you giving all the cycles? Are you doing 2 cycles and re-imaging to see if the target's gone? You know,
Yeah, it's a good question. Yeah, we have quite a bit of experience with it. You know, there are some centers maybe that just give all 6 and then image later, but there are non-responders for sure. So we try to monitor their PSA with each cycle, sometimes doing another PET scan after the 3rd cycle, depending on what their PSA is doing. So I think it's nuanced patient by patient. We are watching them closer.
I pretty much scan after 3. And if they're responding and they're tolerating it well, I'll usually, push all 6.
And if the target disappears, you scan after 3, they say, we don't see any PSMA activity. Do you give another cycle?
Great question. And for now, I do.
Yeah.
I have thought about it. I've had a couple patients who have had more or less a complete response on PSMA PET, and we've kind of had that discussion. In the few examples, they've been go-getters and wanting to keep going. But I have questioned that myself. I think it's a fair point.
Yeah, logically, that's a very hard to answer question. I mean, if you don't see the target and you're given a treatment for it, but consolidatively, I think that would be potentially a mistake if you're not following the full sequence. There is the possibility that if there's still things that are not uptaking that's in a microscopic setting, you may be able to kind of explain for treatment that way. But I do generally recommend the 6. I will scan if the PSA is headed in the wrong direction clinically, or if patient's more symptomatic, if there's something that just doesn't feel right clinically.
Yeah, I think there's going to be a question also about doing more than 6. So that's being looked at. A lot of patients have great responses, and then they progress and want more treatment. So we have to look at that.